Sir, good evening, sir.
Good, good. So I think it's time. Amish, shall we
53
start?
attendees.
Right,
Yes,
right. Awesome, awesome. So thanks very much, guys, for joining us for another edition of Oncology Beyond the Obvious. So far, we have mainly discussed a single publication, okay, and then made it threadbare and given you all the finer points of how much is practically applicable in the real world setting in our scenario. Now, this time, Amish has selected something totally different. And this is also so relevant to our daily practice that I think it is the reason for so many people to join even before the meeting has started. And that is that we are spoiled for choice. In this particular instance of metastatic renal cell carcinoma, we have 5 molecules available as category 1 level 1 evidence recommendations. And therefore, it becomes a very, very important thing as to how we are going to choose one of these 5 for the particular patient that is sitting in front of you. And that brings into the whole equation the wisdom, the insight, and the knowledge that our senior experts have. And therefore, we have chosen Dr. T. Raja to be interviewed, Dr. Vamshi Krishna to moderate the discussion, and Dr. Vineet Talwar to give the concluding remarks. So without wasting much time, Amish, hats off to you for giving one more new dimension to oncology beyond the obvious. And I hand it over to you to initiate the interview with Dr. T. Raja.
thank you, sir. Before we start the interview, as a customary few slides, which I'm going to present. Can I have my first slide, please, Kavina Creations? Yes, and okay, perfect. Next slide, please. So as Parikh sir mentioned, today we are not discussing a single paper, we are discussing a concept. In the first line treatment of metastatic renal cell carcinoma, majority of them are clear cell carcinoma, some of them are sarcomatoid or rhabdoid differentiation and other varieties. But if you can see in the red box what I have put, all you can see on my left hand side is category 1, category 1, category 1, category 1, category 1. There are few important category 2As also, which are seen in the other recommended regimens and some in useful certain circumstances. One gets surprised that how do I select and what do I select? And the data, does it dissect out in favor of one over the other, is something which we thought that we should discuss today. Next slide, please. So this was, I think, March 10th of 2023. That is 4 days before ASCO guidelines question and answer session have come, and the management of metastatic clear cell RCC. And if you see the type, evidence, quality, and strength, they had to give all these things for the choices what we have. So one can understand that how much of we are spoiled with the various choices and what all factors which we need to see when we select a particular regimen for our patients. Next slide, please. And this is an up-to-date, which is again in February 2023, which was updated. Systemic therapy for advanced clear cell renal carcinoma. And I'll highlight few points about it. Next slide, please. So this is, single agent anti-angiogenic therapy and single agent immunotherapy. Now, this is not something which is either of them is an approved category 1 recommendation in NCCN or in US FDA, but the up-to-date and Walter Kuhr's publication says that in a favorable risk patient in a limited disease burden, you can select either of these. You will not be wrong in that. Next slide, please. So that means 5 plus 2, that is, we have 7 choices now. Cure or only treatment-free interval. Now, this is a unique concept in metastatic RCC. Are we looking at treatment-free interval of 6 months, 1 year, 2 years, and that's when the actuarial survival concept comes? Or, sort of a new concept, which first time I remember in OBTO platform, Dr. Shyam Agarwal had introduced, and I'll just present that. Do we really can we really use the word cure is a question which we need to understand. Next slide, please. So this up-to-date authors have said that Nivo plus EP is the treatment to go for if you are looking at treatment-free interval or if you want to use the word cure. And in my two red boxes, what I have shown is a flat line. A flat line, the top is the PFS, that is at 2 years. If you are still having PFS advantage, you will continue to have it for next 3 years. And the bottom, exactly the same wide up graph is there because the durability of response, again, that is also a flat line. Next slide, please. For 3 good years, there is a flat line, please remember. And this is what I was talking is a new concept in immunotherapy is called as a conditional overall survival. What it means is that at a particular time point, say for example, at 1 year or 2 year, where are you standing? Depending on that, will you continue that status for next 2 years is something which these graphs give us. I'm not going to go into the details of that, but this in clinic, I have started explaining to my patients that if you achieve this particular landmark, then next 2 years, you are definitely going to be disease free or you are going to live better. And that this really helps me. Next slide, please. This is what I said is pembrolizumab monotherapy, which was in ESMO 2021, 41 months of follow-up was presented. Next slide, please. And this is what it was, basically favorable and intermediate and poor risk. And if you see on my right-hand side, the overall survival, it's actually a comparable to any other combination. So you have to select out your patient for pembro monotherapy and you can't be wrong and you will not be wrong in that. The next slide, please. And this is another unique concept, avelumab plus exitinib, Javelin 101 renal. They still don't have the complete OS mature data and we are waiting, but they were the one who first tried in biomarker directed outcome, that is PDL1 and PFS according to CD8 plus cells at the invasive margin. So there are new concepts which are coming up. The last slide, please. Next slide, please. So basically, again, the question still remains what to give in which patients. And that was my last slide. We can go over to our interviewee, none other than Dr. T. Raja sir. Can we stop the slideshow, please? Okay, perfect. So it is my honor and my privilege to introduce Raja sir. Dr. T. Raja, I think, nobody in this medical oncology or oncology community would be so naive not to know about him. But, just a few lines about him. He did his MBBS from Madurai. He did MD in peds, like I have done my MD and DNB in pediatrics. Sir has done MD peds from BJ Medical College. Sir did DM from Gujarat Cancer Research Institute. I didn't know that sir has a Gujarati connection, and no wonder, sir has such a magnanimous personality. He was, in addition to that, he was a gold medalist in GCRI in DM. In terms of the award, sir also has been given award of Best Doctor Award by the Tamil Nadu Dr. MGR Medical University. Sir has been or had been adjunct professor in the University of Queensland in Australia. He is the director of medical oncology, Apollo Chennai. He is heading the DNB program also. And of course, he has multiple publications and he holds many conferences which are actually unique. Apollo Conclave is something, which we have been seeing and hearing and attending for last so many years. So these are his qualifications and his achievement. But what uniquely strikes out about Dr. T. Raja sir is two things. One, he is an extremely humble and nice human being. When you see him, you feel the warmth is coming from his side and he will always hold your hand and tell good things about you. And that will make your day. And second thing is his PPT slides are, my God, so full of information. And I always wonder, how does sir get time to write such rich slides? And it's always a pleasure to listen to Raja sir's any lecture, or if he's moderating any of the panel, you always go home learning. Thank you so much, Dr. T. Raja sir, for accepting this invitation, for being interviewed on today's platform, sir.
Thank you, Dr. Amish. And it's our honor and our privilege to join you, the OBTO. I did mention at the start of this conversation today, OBTO has been an extraordinary journey and a great concept. I must really commend you for initiating this in-depth analysis of either a paper or today, as Purvish Bhai said, a concept. I think that brings real depth into what we, and then a lot of, finally, the focus is on take home, takeaway. I think this has been phenomenal. We are very honored to join you. Thank you so much for all the good words.
Thank you, sir. Before I ask you the first question, just a comment. I always used to wonder, Raja sir हमेशा Purvish sir को Purvish bhai क्यों कहते हैं? I think GCRI का connection बाहर आ रहा है. Looks like I'll start my first question, sir. Sir, like non-small cell lung cancer, and just giving one example, and in renal cell carcinoma, we have multiple category 1 recommendations. Forget about kidney. We are not talking in general, sir. When you are spoiled with the choices, what are the few thought processes which come in your mind when you have to decide that in front of the patient in your OPD, sir?
I think, as you rightly mentioned, I think you showed some excellent slides. As what is meant by two things that NCCN commonly uses, and we are all really guided by NCCN strongly across the world. NCCN uses category 1 recommendation and category 2A, B as one of their recommendation, and then it also uses another term called preferred, and then other options. That's how it tries to say. So we know that category recommendations, category 1 is based on the level of evidence and then the strength of the consensus, whether there is a uniform consensus. And then we all know that 2A, 2B is, there is uniform consensus, 2B is there is some discordance, but we know that there is no major discordance. That's how we divide. But when we look at the preferred, again, how do they say it is preferred? The level of strength of evidence, then how much of consensus is there? Beyond that, they look at other things, toxicity. And one interesting aspect is that they also look at access, and that means they look at finance and the patient tolerance and all that. So I think they give a lot of leeway to the clinician to make some decisions. That's what we all like about our NCCN recommendation, trying to be elite at the same time practical. So, and then the other thing that I wanted to just touch upon is that if you look at the NCCN recommendations, category 1 recommendation, incidentally, I actually looked at it just for this meeting. The highest number of category 1 recommendation is actually for renal cell carcinoma. That is, then next to only is breast cancer, and the lung and all comes. So in renal cell carcinoma, there is a lot of unanimity among the experts. That's really heartening, considering the fact there is so much plethora of options available.
Right, sir. Thank you so much, sir. So we have a lot of grounds to cover, so I'll go little run my questions. Second question, sir, is except for Checkmate 214, that is the Nivo-EP, where they have a combined primary endpoint of OS also, and they have a combined secondary endpoint of OS also. All other trials, all the 6 randomized control trials, what we have today, the primary endpoint is PFS. And if you see, renal cell carcinoma, sometimes patients live longer. So do you really think that the PFS, I'll just give you the numbers. PFS of pembrolizumab is 0.39, which is really an outlier. For nivolumab and cabozantinib, it is 0.51. And the other two, avelumab, exitinib, and pembro-exitinib, it is standing somewhere as PFS of 0.71. But if you see OS of 2 years, they are all standing somewhere as 0.69 to 0.71. Do you really think that PFS should be the ideal primary endpoint? It is just rushing through. They all want their drugs in the market, and that's why they are selecting sort of a PFS as an underrated or overrated primary endpoint.
Your question is right, but I think in a metastatic setting, PFS is a very valid, primary endpoint. Of course, they have a secondary endpoint, as you mentioned, the overall survival, and then safety, everything comes into picture. And what you pointed out is the hazard ratio of the PFS. That's what you pointed
Right,
out.
sir. Right,
And,
sir.
and then, as you rightly pointed out, if you look at the PFS of pembrolizumab and lenvatinib, the PFS is again an outlier at 24 months with a hazard ratio of 0.39. That's very, very excellent. But if you look at pembrolizumab and axitinib and nivolumab and cabozantinib, the PFS is 15 months and 17 months with a hazard ratio of 0.71 and 0.51. And but if you look at the overall survival, most of it is not reported, but we have the landmark overall survival at 24 months. As you rightly pointed out, all of them, whichever is reported, even the IPNIVO, the overall median overall survival, the overall survival at landmark 24 months is 70%. Pembrolizumab axitinib is 74%, and pembrolizumab lenvatinib really stands a tall skyscraper at 79.8. That's close to 80%. So if you just pick that pembrolizumab lenvatinib and then try to answer your question, what is the message it's saying? It is saying that a very impressive PFS and a very impressive landmark 24-month OS of 80%, nearly 80%, and a safety of acceptable grade 3 to 4 toxicity of 72% with a discontinuation rate of 10%. So that clearly tells us that here is an option which will give you a real quick start and a real bang for the initial buck. And then you talked about the OAS being, more or less similar at 70 at the landmark analysis, because in some of these trials, we also look at the flattening of the curve. We clearly know that in the IPNIVO combination, we start to see that by the month 9, the curve separates. By the month 30, there is a flattening of the curve.
So we'll talk about the flattening of the curve in a second.
So
But
I think the short answer is PFS and ORR are very, very relevant.
Very relevant. So, sir, the next question, you talked about pembrolizumab and lenvatinib. And it is an outlier and amazing hazard ratios, impressive results, and impressive ORR of 72.5, which is the highest reported so far in mRCC. But so my simple question to you is, lenvatinib given was at 20 milligram. So are we able to give 20 milligram in our Indian patients? One. And the second question is, if we are not able to give 20 milligram, can we duplicate the result, what is there in the clear trial, by the lower doses of lenvatinib, sir?
Yeah, that's a very relevant question. If you the original dose is 20 milligram, but if you listen to the various lectures by the original authors themselves, you would understand that immediately they talk about their own difficulty in conducting the 20 milligram. One, they acknowledge that 20 milligram is not easy in the so-called good Western population. And then the second thing they also allude to is that whenever there is a need, they say that they all start at 20, and whenever there is a need, they don't hesitate to bring down the dose. This is exactly the word they use. And then the third thing they also say is that just by reducing the dose, they try to tell us that the efficacy is not lost. And we also know, particularly with regard to the TKIs, whenever there is a toxicity, it's kind of surrogate for efficacy. We know that toxicity in various TKIs tells us there is efficacy. So I believe if the titration is done as per the patient's tolerance, probably the efficacy will not be lost. That's my take on what, and they also have difficulty is what am I alluding to.
That's great, sir. So it is very good to know that you are strongly believing that you may start lenvatinib at 20 milligram, but depending on the patient's tolerance, you can reduce and still you will be able to replicate the results which are published in CLEAR trial. Thank you so much, sir. So before we come to the specific various options, 5, 6 options or 7 options, what we have, one thing which is there is, do you really think that PD-L1 matters in mRCC, or will we ever have other biomarkers which will help us in selecting the schedule or the type of the drug which we give?
Yeah, interestingly, we all know that renal cell carcinoma there's a lot of immune-driven disease, but there are no perfect biomarkers available for us to select, which I think will be the next frontier to conquer with regard to the next design of trial for renal cell carcinoma. And as you pointed out, one of the specialties of one of the trial, that is the axitinib avelumab trial, the Javelin 101, that has that's a randomized trial in which 400 odd patients on axitinib avelumab versus sunitinib 400 patients, in which they have reported the data on PD-L1 patients separately. That's about 250 odd patients on both the arms had PD-L1 positivity, and they have tried to look at that particular data and try to report that, separately. And just to give you a flavor, the response rate and the CR rates in PD-L1 positive patients are slightly higher with axitinib avelumab as compared to the overall group. The other trial which you pointed out, I think the Checkmate 427, which is the pembrolizumab single arm study, is another study where uniquely they have also again stratified based on their PD-L1. CPS more than 1 has been found to be having a more favorable response. So these are 2 trials that have talked about the PD-L1, but I sincerely believe that we need more biomarkers to look at RCC so that we can start to predict which are all the patients who are really going to show those flattening of the curve. Of course, clinically we have some ideas, but still I think biomarker driven approach will be useful. As of now, PD-L1 is the only available biomarker as per these 2-3 data set.
Sir, mRCC, if you have to answer just yes or no, in mRCC or metastatic RCC clear cell, if you have to select a particular combination amongst the 6 or 7 options what you have today, does PD-L1 help you or no?
The answer is no.
Okay.
No.
As of now, no. Perfect. So let's come to, sir, now Nivo-EP, and then we will talk about the IO plus TKI or IO alone arm. Let's talk of nivolumab and ipilimumab. This is the 55 months follow-up, which is the highest reported so far in metastatic RCC domain. One of the unique thing about Checkmate 214 is, sir, if you see the hazard ratio 2 years onwards, that is the 3rd year, 4th year, 5th year, it's standardized, it remains at 0.69. And, I also showed the conditional overall survival, the slide. While in a combination of IO plus TKI, if you see like Keynote 426, for example, that is also one of the oldest trial which is available, 0.53 hazard ratio at 1 year reduces to 0.68 at 2 years and reduces to 0.73 at 3 years. So there is no flattening. So my question to you, sir, is which are the patients in your clinical practice where you would give nivolumab plus ipilimumab combination over other combinations? And do you also use the word cure if any of these Nivo-EP at the end of 5 years only on nivolumab arm is doing well and they have not relapsed?
So nivolumab, ipilimumab is a very, very interesting combination. It's one of the kind, doublet. So we all know that it is one of the earliest 2018 read out published, and that's the first landmark study that really opened the gates for immune checkpoint inhibitors. The pembro axitinib came in 2019, and thereafter all these trials came. So initially we were worried about the curves going together, but they started separating at 9 months. And as I mentioned, it started, started flattening at 30. And once they crossed the 35th month, we really, once it crossed the 3-year, or we really saw that it was really flat, and 35% of the patients remained to be flat. So that's very unique about nivolumab IP combination. So which are the patients that will come to my mind whenever I want a durable disease control? Whenever I want to look at that plateau of the OS and the PFS, and that is when I really look at Ipi-Nivo, and I probably look at one another couple of other important things about Ipi-Nivo. And the Ipi-Nivo is very special about this, its efficacy in the sarcomatoid variety. I mean, in the sarcomatoid variety, Ipi-Nivo has a very, very standout overall response rate of around 60% and a CR of around 18%, and it gives a PFS of 26.5 months. So definitely for sarcomatoid variant, Ipi-Nivo is really, really unique. And the other thing about Ipi-Nivo, since you asked the question, is where do I place the Ipi-Nivo? What the NCCN says is that in the poor risk and intermediate and poor risk is where the Ipi-Nivo is currently category 1. But whether I can use it in any other places. So whenever we try to choose patients in favorable risk factor, when there are 0 risk on IMDC, favorable risk, then the next thing that comes to our mind is what is the disease burden in this patient? Whether the patient has got a limited disease burden or a substantial disease burden. In patients who have substantial disease burden in the favorable risk, you are not wrong in considering, Ipi-Nivo. And if you put a patient on and in a favorable risk, and if you have a limited disease, and if you have opted to surveillance a patient, and if the patient has progressed on surveillance, that's another patient where you can consider Ipi-Nivo. In what I'm trying to say is there are some subset of patients where Ipi-Nivo can be useful even in the favorable risk, but otherwise it is to be used in the intermediate and poor risk, particularly when the patient is not very symptomatic, not very life-threatening, where you are not worried about a quick progression. And then you are wanting to capture that flat OS and PFS. That's when the Ipi-Nivo will be your choice.
Right, sir.
Other important thing is two other important things. One
Yes,
is
sir.
reverse toxicity. The Ipi-Nivo toxicity is all reversible, whereas the IO TKI combination toxicities are cumulative as we go on. That's important. So you also look at the patients in whom you think that they cannot have the VEGF toxicity. That's your Ipi-Nivo. And the last thing is there is a concept called TFS, that is treatment-free survival. Once the patient achieves a good CR, it is said that around 80% have an ongoing response. And even if a PR, about 60% have an ongoing response. And the TFS is very, very unique about Ipi-Nivo, that with or without toxicity, treatment-free survival, if you discontinue also, many of them continue to be treatment. So these are all the things that you want to talk to your patient.
Understood. So that's a very, very good Nivo EP. This thing, I get impressed by Nivo EP in other diseases also, because if you select, I believe that if you select those 15 to 20% of your patients correctly, they will live longer, they will do wonders about it. But point is that which are those 20% who will respond well? Sir, we have 7 to 8 minutes more. So I'm going to take a case scenario with a different aspects of it. And you have to, sir, you don't have to give me multiple answers. You have to tell me between Pembro-Exe, Nivo-Cabo, Pembro-Lenvatinib, and Evolumab-Exitinib, if with whatever. And because you have also sort of presented your data of 102 patients, out of which 40 patients you have given immunotherapy in either alone or in combination. And I saw that paper which you had forwarded to me. This was 2018 and 2022, where you had collated your data. So I'm sure you are the right person to answer this thing. A 62-year-old male, metastatic RCC, good risk. So the first case scenario is 3 lung nodules, performance status of 0, asymptomatic.
So you said good risk and performance status, good performance status. So and the patient is asymptomatic.
Patient is asymptomatic.
So probably he may be a good candidate for the following choices. He may be a candidate for even surveillance.
Correct.
Otherwise, if you think that for some reason you have to treat, this is an ideal patient for a single agent anti-angiogenic therapy. It's possible, or even a single agent pembrolizumab and nivolumab will be a very good choice for this patient.
Perfect, sir. Absolutely correct. I completely concur and agree with you, sir. So second case scenario, 3 lung nodules, 2 bone lesions, and symptomatic for bony lesions.
The patient is already symptomatic, but
Yes.
what will be your IMDC risk?
So still good risk.
Still good risk.
More than 1 year, all parameters of calcium, platelet, everything normal.
So this patient needs the standard of care. Current standard of care is you have to add the immune checkpoint inhibitors at some way. And for favorable risk, the immune checkpoint inhibitors choice is to combine immune checkpoint inhibitors plus any one of the TKI. What is your, in that I would say that it all depends on the familiarity of the treating team, how comfortable they are with, we have the choice to treat with pembrolizumab axitinib. You have the choice to treat with pembrolizumab lenvatinib, or you can even consider nivo cabozantinib, or in some patients you can even consider axitinib plus avelumab is also a
So
possibility.
in this patient, what would you select, sir?
Yeah, I just like what you said, we looked at our data. We started using immune checkpoint inhibitors from 2018. That's our first patient on nivolumab single agent. And that patient is still living in CR. That's the image that I sent to you. More than 5 years, single agent nivolumab on a second line. From then on, we were totally sold on. So in 5 years, we have collected about 103 metastatic RCC in which we tried to give immune checkpoint inhibitors. 40 of them could take immune checkpoint inhibitors. And then we have the data on first line, second line. We talked about it. But the most familiar one that I have used, because in 2019, this pembrolizumab data came. So from then on, that is my largest experience. But then recently now we use more of nivo cabozantinib and some odd patients on doublet. That's what we've done. So my first choice in this patient will be pembrolizumab.
Perfect, sir. So we have 3 or 4 more case scenarios. I want 1 or 2 answers, sir. So the same 62-year-old male RCC now is intermediate to high risk and has lung, liver, bone metastasis, but not a single organ is damaged. Everything is perfect. Patient is borderline symptomatic, not very symptomatic, but intermediate to high risk, and 3 organs which are involved. What would be your choice?
So this is very clear. He has more than one intermediate high risk, and he is borderline symptomatic, and he has a disease burden that involves major organs. That is considered as life-threatening disease burden. This patient needs a quick ORR and a quick PFS, quick symptomatic. So you need to go for the big punches. So big hitters, you need pembrolizumab lenvatinib in this patient. That will be my first choice.
Perfect. So the same patient, he is symptomatic and has liver dysfunction.
Okay.
What would you use?
So then probably in this patient, I may consider is symptomatic also. Then I need to look at
symptomatic and liver dysfunction, sir. LFTs are abnormal.
Okay. I may still consider my choice will be pembrolizumab and axitinib because I'm a little bit more comfortable with using axitinib and the dose modification. That's what I will.
Dose modification. But sir, if somebody wants to use pembro lenva, I think isn't this is the patient where you would want immediate response, or you would shy away from using such high dose of lenvatinib in liver dysfunction, sir?
Yeah, that's the trouble with lenvatinib. That definitely there's a dose reduction that is needed. That's when I said I'm more comfortable with axitinib dosing. That's my
Perfect.
personal choice.
So same 62-year-old male, metastatic RCC, intermediate to high risk, but has a history of cardiac dysfunction. 2019, there were 2 stents which were put. Patient is on right now on ecosprin and clopidogrel. What would be your treatment of choice?
Again, in this patient, probably I may be, but if the patient is not having a,
Patient is not symptomatic, sir.
yeah,
It's intermediate to high risk, but patient is not symptomatic.
I will choose a doublet here, Nivo-IP.
Nivo-IP. Perfect, sir. In fact, majority of the experts across the world said that in a cardiac patient, try to avoid TKIs, at least especially anti-VEGF TKIs, because patient can have hypertensive crisis, clots, blah, blah, blah. So the last question, and after that, I would, request you to, I give you 1 minute to summarize. If the same patient who is intermediate to high risk, borderline symptomatic, but is 76 years of age, what would be your choice?
I mean, age is not a deterrent. I think immune checkpoint inhibitors will still be a very good option. And doublet immune checkpoint inhibitors may still be an option.
If very symptomatic and you need immediate ORR and you have to use TKI, which TKI in elderly would you select, sir?
I probably will again go for pembrolizumab as my go-to choice.
Right, sir. Sir, it looks like we are comfortable with pembrolizumab, and that's the reason. So last 1 minute to you, if you want to give some take-home message to people who are listening to this, and after that, thank you so much, and I hand over to Parikh sir for that, sir.
Thank you so much. I think the take-home message is that the most important, there is a plethora of choices, as Dr. Purvish bhai pointed out, and also Amish pointed out. So we quickly look at the risk stratification, which is something important we need to do. Then we look at the disease burden, and then whether the patient is having symptomatic disease or whether the patient has got significant life-threatening, and then what is the kind of toxicity the patient can tolerate. And then you need to look at the goal of your treatment, whether you need a very quick ORR, PFS, and whether you are trying to capture that plateau phase of the OS, and then whether it is, of course, a clear cell sarcoma and all that. So these are all the important things that one would want to look at. And there are some more interesting options coming around. The sunitinib as the comparator arm is definitely already outdated. So the newer trials are looking at Nivo plus cabozantinib and then to add a Nivo-IP cabozantinib, that's coming up. And then you also versatile use of Ipi-Nivo, and then trying to operate cytoreductive nephrectomy after the Ipi-Nivo, and then to combine Ipi-Nivo plus RT radiation is happening. And lastly, very interesting, among all the solid tumors, CAR T cell has got a role in RCC, and fourth generation CAR T and then it's very close, if at all, in any solid tumor. That's RCC, and of course, how we are going to learn the newer molecules like the HIF2 inhibitors and all. So whether they will come quickly into the portfolio. Something interesting. RCC is still exciting. Thank you. That's what I can say.
Thank you so much for this, sir. Over to Parikh, sir.
Thank you very much, Dr. Raja and Dr. Amish. I think this was a fantastic topic selected, and Dr. Raja really went into the intricate details of how to select. So I think your last 2 aspects. One is what are the parameters or criteria on which the selection is made, and the second is what is that we should expect in the future. I think that has been really a very important take-home message as a summary of the entire interview. Once more, thank you very much. And now it is time to move to the panel discussion. It is my honor and privilege to invite our moderator, Dr. Vamshi Krishna. And the panelists are Dr. Amit Rautan, Dr. Bhuvan Chug, Dr. T.P. Sahu, Dr. Vineet Govinda Gupta, Dr. Raja, of course, stays back as one of the panelists, Dr. R. Rajkumar, and Dr. M.V. Chandrakant. So, Vamshi, without taking too much of your time, over to you to start the panel discussion.
Thank you, sir, and good evening, everyone. And this is a very interesting topic. And as usual, as OBTO has it, what I would do in the next half an hour or so is try to dissect the data first, and also try to see what we do in our real life and our real practice. So that's what I'll be doing. If the organizers could share my screen, please. Oh, yes, thank you so much. So the next sometime, what I will do is, we are seeing a mixed screen here. Is that okay? Go back one slide, please. So I would be talking about the I would be talking about the trials, and then we would also be discussing with all the panelists what we can be doing here. Can we go back one slide, please? Yeah. So I request all my panelists, let's have a scientific discussion and also discussion when appropriate about what we'll do for our patients. Let's not start by saying if affordable. We are all aware of the costs of the medicine. So let's not dilute the whole topic by saying only if affordable. We understand the costs and we will discuss that in its appropriate place. Now, when we talk of first-line combinations available in India, we have the pembrolizumab, Keynote 426, we have the pembrolizumab, the clear data, avelumab, axitinib, Javelin, Nivo cabozantinib, Checkmate 9ER, Nivo EP, Checkmate 214, and we do have atezo-bev, which is not accepted now, the iMotion 151. We have the Cosmic 313 results. Now, it is available only in abstract form. Dr. Raja alluded to that about the Nivo Cabo plus EP data. And that also showed a PFS advantage. I have deliberately not put it since Dr. Amish has nicely said we should discuss the 5 options, but this also is one of the options, right? Next slide, please. So what I will do is talk of these things. First of all, are all our patients eligible for all the combinations? Second, what cross-trial comparison should we do and what exactly are we looking at when we do a cross-trial comparison? Then we'll come to what we do in our clinical practice. What do we decide or how do we decide? I want all the panelists to opine on this fact. Do the combinations actually matter? Are all the IOs and TKIs the same? Are they interchangeable? And finally, as someone has already asked in the question box, we will ask whether the time is right for low dose IO, and that is something which we do talk about. So that's what we'll be doing in the next 30 minutes. Next slide, please. So first things first, let me start off with Dr. Vineet. Dr. Vineet, prognostic models, the MSKCC came in 2002, the IMDC came in 2008. Are we still following these models? Dr. Vineet Gupta? Vineet,
yes, so for purpose, so actually all these studies, they have used the prognostic models to, dissect out the degree of benefit in various subgroups. So we are using, and I think we should be using while utilizing these instruments.
We are using and we should be using. Excellent. Dr. Sahu, your thought? Are we comfortable using this even now?
I think IMDC is something that all of us have shifted to and we should be. It's more of a TKI. The later on, do we have something very appropriate for immune checkpoint inhibitors? I don't think so. We have developed a model as per that. But most of the trials are still following the IMDC, most of them, and have categorized the patient as per that. So that will be a very practical way of approaching it.
Fantastic. Next slide, please. So there is some data. There was a small paper from the ASCO GU last year where they looked at this specific point, immunocombination results from the IMDC. And again, it showed that there was a difference between the poor and favorable. There was a difference between the poor and intermediate. So essentially, what they said is that yes, in the multivariate model, all these factors still hold good. So that decision, whether we should use IMDC or not, is kind of, I think, accepted. And like Dr. Sahu said, there's nothing better. Let's go ahead and use it. Next slide. So what I would do is, now a patient walks into your office. Dr. Chandrakant, patient walks into your office. What do you look for? And before you can answer, are we specifically looking for PS 0 or 1 only? Or is our definition a little elastic and we say, okay, even PS2, we are happy to treat as per our usual protocols?
True. So performance status is important in all cancers, and IMDC in itself has a performance status inbuilt in it. Therefore, if the performance status is poor, it gets reflected in the IMDC score in itself. I agree, PS2 does have a substantial number of patients in my practice.
Okay. Dr. Raja sir, your thought on this. Should we stick to a clinical trial when we talk of, this whole discussion of 5 or 6 combinations? Should we stick to the PS0 to 2? We have patients of 3 and 4, anecdotal responses have been there. Should they be treated the same, or should we just, put a hard stop to this and say, look, your PS4, you will not get a benefit from this protocol. You should be treated separately.
I think these are very demanding protocols. I mean, if you want to use them well, and that also partly answers one of the questions that you showed earlier, that does this combination matter? And you asked a very interesting question. I was looking at that question. It matters because, when you want to treat a patient, you also want to be familiar with something what you're doing. That is what why would a team become comfortable with a particular protocol? Well, because it's a question of using and getting acclimatized. So when you have a combination that's written, executed, and published, so the track record, the toxicity, how it was managed, and you can learn so many things from the already available data, and then you want to put it on your practice. And then you don't want to be facing surprises. The patient brings variables, but you don't want to introduce too many variables. Therefore, even though the concept is that IO plus TKIs are all it is there, but you still wanted to go with these tested models because you want to be familiar. Same way, if you look at all the trials, either it is the PS01 or it is 70. That has been the cutoff. So I think we should stick to that. Beyond that, then you should have an individualized discussion with the patient, their appetite for taking the treatment, and your overall assessment, various other factors. Then you are little out of the what you call standard of care. Whether a physician has got right to treat, that there is definitely physician has got all the leeway. That is art of medicine. But then you just, for the sake of what you call that legality, let's say, just spell it out and then exercise your art of medicine. You are at liberty to do, but then exercise clarity there. That's what I can say.
Fantastic. And I really wanted this message to go out to all the audience. If your patient is PS3, 4, please do not look at NCCN and say, okay, doublet I am not giving. Am I doing something wrong? That is not the message. The message is very clear. Anything which is higher bad PS, they do badly. Document that fact, and you're well within your rights to not give the so-called standard of care, because those standard of care are not designed for such patients. This is especially true if you're practicing elsewhere and a patient walks in with an opinion taken from different parts of the country or the world, which is a common occurrence for us. Remember, you are the one sitting with the patient, you are the one seeing the patient and the performance status. So I think that's a message I wanted to go out, which is why I put this. Great. So next question, Dr. Amit. Patient walks into your office, PS01, we now know that. What do you look for? So what I'm trying to come is, would you look at the patient features, the reports, and say, okay, this guy fits into this clinical trial, and so I will go according to this? Or would you say, okay, this is my experience or my comfort and I will do this? How would you go about it, Dr. Amit?
So if a patient enters office, the first thing, how symptomatic is the patient? That's the major thing we look at. And then when we start looking at all his reports, we try and put him into the IMDC criteria. So RCC in many ways has made it very simplistic for us. Just the performance status, symptoms, and IMDC is good enough to take a first-line decision. I don't think we'll be wrong anywhere. It's just that,
okay, next slide, please.
I personally would have said, it's very sad to see that we are in this era of molecular oncology, but this is one cancer where an IMDC is a basic decision maker for everything, where we can't talk of NGS, we can't talk of testing, we can't talk of biomarkers, but that's the reality of RCC.
Fantastic. I, for one, am very happy I don't have to discuss all that again and over again. I'm tired enough of discussing NGS with every patient who walks into us. On a lighter way, however. Next slide, please. So this is why I'm asking. The trials all have used good risk, intermediate risk, and poor risk patients in more or less similar proportions. The only exception being the axiavulumab, which had less of poor risk, and the pembrolizumab, which had a higher amount of good risk patients. So this one thing is there. Otherwise, all trials have used similar disposition of patients. So when you look at the IMDC, I mean, personally, I would be happy that IMDC is still holding strong. And the IMDC is used in all the clinical trials. So all the trials have used drugs across these things. Next slide, please. So now I'll just go into the data. Now I'll spend around 10-15 minutes on the data that is there. So let me start off again with Dr. Chandrakant. When you get the hold of this data, 5 different studies, 6 different studies, what are we looking for? Are we looking at the overall survival? Are we looking at the PFS? Are we looking at the overall response rate? And of course, I know you'll all agree with me that it's all of the above. So all of the above anyway we look at, but beyond that, what is the one thing that you really want to focus on in these patients?
So in any metastatic disease, I will look for overall survival and quality of life. So these are the 2 things which I would look into. Of course, responses and PFS are surrogate for these, but these are the 2 goals and endpoints. Overall, how long the patient lives and how well the patient lives.
Dr. Rajkumar, your thought on this. Which is the one thing when you're sitting in, you're going through the data, you want OS, PFS or ORR? Which is the most important thing for you?
The tablet column which you have shown earlier, majority of the trials holds only 13% of the patients in all the trials are poor risk. But in the real world practice, what I am seeing and what majority of the panelists must also encounter, the poor risk subset are high tumor burdens are the most common thing which we encounter in our real world practice. Many of the patients do come with multiple sites of metastasis with all the tumor going up to the IVC in the right atrium. So those kind of multiple bone metastases with the highly symptomatic, high tumor burden, where I like to have the response little bit earlier, rapid response. So I tend to use the TKI combinations of TKI plus IOs. Majority of my patients are in these subset of poor risk, unlike the trial-based one, which forms only 13% of the thing. So I like to have a good response, make the patients little symptom-free. And of course, all other do matters, but I like to have a TKI-IO combination upfront when I am encountering a poor subset of patients and when I'm seeing a high tumor burden.
Very good. Dr. Amit, your thought on this? And then I would ask you also to give your experience. I know you have a big data set of RCC patients. You're one of the persons who have been following for a long time and you keep talking of your experience in RCC. Do you agree with Dr. Rajkumar that we have a much higher proportion of these poor risk and intermediate risk than the good risk as compared to the clinical trials?
I would say, yes, we do see more of poor risk, but actually in the whole, if I look at it in practice, you do see good amount of favorable risks also, which are coming in, who had been operated many years back and now progressing and coming in. So I would say, no, we do have favorable risks also. I don't think I would say number wise, we are all sitting into that in one subgroup itself. But what I do agree with is in many of our patients who are symptomatic, high risk, intermediate risk, all of us want response. Because if our patients don't respond, they're not going to get that PFS and that OS, which we keep talking about. So all of us want some form of response, and then we want that some extension of PFS. And then, of course, OS is something that comes out. And I agree in many ways, all of us, because in India, IO-TKI was so accessible to us much, much earlier than IO-IO. So IO-TKI became the way forward in India for us, which is contrary to what happened in the West. For them, IO-IO came first. So they talked much more about IO-IO for years, and then the IO-TKI is what they talked about later. For us, IO-TKI became our go forward. I think it's been 4 or 5 years since we have been using IO-TKIs, and all of us are very familiar. Yes, I know you will get to which IO and which TKI, but I think IO-TKI is what I sort of lean towards naturally, because that's what we are very adept at. IO-IO is something newer for us, and that's something I would say there's something we choose much more carefully.
Okay. Dr. Sahu, so 2 questions to you aside from this point. I would like you to answer this. Then next thing again, which Dr. Rajkumar said, high proportion of interval. Is it because staying in a tier 1 city, possibly we are seeing more follow-ups, like Amit is saying, we get more favorable? Is it something to do with the location? And number 2, something which Amit is talking that, we have had access to IO with TKI for the last 5 years. To be honest, I don't know how many patients really afford it so much. So do you really agree with this statement that the access to IO-TKI is much, much longer than an IO? These 3 questions which you can answer.
Yeah, first thing is about the poor risk, what you spoke about. If you look at the trials, why they have so less numbers, which is actually much lesser than what you see in real practice, is the entry criteria of 0 to 1 PS. So once you make it as an entry criteria, most of these patients who would have been in the trial sites also would not be eligible for the trial. So that is the more practical issue. So every one of us would be seeing more poor PS patients which would be into high risk actually, because the bulk of the disease also would be much more. Point number one. Point number two, what I want to make of the data, and then I come to Amit's point. I just look at 2-3 things very, very carefully, practicing in not so affordable patient group. I definitely look at the OS as my first thing, what I look into. The response is second. I also look very carefully at the discontinuation rate and the toxicity, because we normally do not account that for when we are looking into the cost factors. And many times there are cost factors which accumulate on when there's a toxicity issue. Now coming down to the last part which you spoke, can you repeat, Vamshi?
So I just wanted to ask you the same thing what Amit was saying, that we are naturally tilted to IO-TKI because we have been using it for a longer time as compared to IO-IO.
Expectedly so. And even if you correlate the data, if I have both the options available today, very few patients of mine would actually be eligible for a IO-IO as my first line preferences, even if they were available 5 years before us. Because there are a lot of issues. I think we'll discuss that why IO is probably not the preferred option in a lot of patients. But I think most of us go towards because of the earlier entry of this combination. And also you have issues with IO-IO. You can look at the graph which Dr. Amish showed, the lovely nearly stagnation and the plateauing of the curve. But you also have to look into the patient group which really can be eligible for this graph.
I will come to that graph and the discussion on that. Dr. Vineet Govinda, your thought on this ORR, PFS, OS. So far, we have a mixed bag. Some want OS, some are happy with a good PFS, some want a response rate considering the bulk of disease. What is your thought and how do you look at this point when you are perusing the data?
Yes, sir. So I would say that if we have to pick between these three, so one thing is that patient who have got bulky disease, response is most important, because if they don't get response, they're not going to reach the PFS or survival endpoints. And for rest of the patients, suppose you have asymptomatic patient with low disease burden, still I think OS is the most robust endpoint, and we should look at whatever cross trial comparison we do. The first thing we should look at is, I think, the OS. But for patients who are symptomatic and who have got higher burden disease, then for them ORR is equally important. And we know that RCC, there are multiple options. We have got long treatment history. So in fact, I am less inclined towards PFS, because always you can give drugs sequentially, or you can give them second line, third line, and so forth. So I think response and survival are the most important endpoints.
Very good. We'll come to this point later. So next slide, please. So Dr. Raja has already given in his interview all this, so I'm not asking him again for this point, but I will bring him in later. Now, these are the 5 trials that we have talked about. And if you look at this, now it's something that I have tried to keep all the things together. Now, when you look at the time, these are the latest updates. The Nivo-Cabo also was done last year. And look at the time of follow-up. So, one by one, let's just go one by one. Chandrakant, when you look at this data, you have something which is 67-month follow-up, one which has 13 point. Can you go back, please? Yeah. Can we go back to one slide? And we have one which is only 13.6 months. Chandrakant, does that matter to you? Because you're talking of 5. The second I look at something which has a follow-up of 40 months and something which has follow-up of 14 months, my intention to compare the two becomes slightly different. What do you think on this follow-up business?
True. I mean, the trial that has the longest follow-up is always preferred. Pembro-Axi and Nivo-EP are the winners in this. But Nivo-Cabo, we have been using Cabo for quite long, Nivo for quite long. So we know these molecules for quite long.
Cabo was launched 8 months back in India, Chandrakant. So 8 months is a long time in India.
So I mean, if I have to use
access to the original drug,
if I have to use Nivo-Cabo, I'm not taken back just because the data is short. I'm comfortable using Nivo-Cabo. So because we have been using these drugs quite long. So just because of a shorter follow-up, I won't use the regimen, maybe no.
Okay, so the follow-up is not as important for you. You want to look at the hazard ratio and the other things. Dr. Raja sir, PFS, we keep talking, and this is something that you alluded to. The PFS of Pembrolizumab is 23 months. And somehow the sunitinib also seems to underperform a little bit. I mean, it's around 8 to 11, so it's around 9 months there as well. Then you have a PFS, which is in Nivo-EP the same as sunitinib. and you have in others around 16, 13, and 15. Now throughout the discussion, we have had people saying that PFS is something that is very important for me. And so where do you place this kind of PFS? Should we do a cross-trial comparison and say, yes, PFS is good, so that's what I would select? We are coming into the field of what combination to select now.
Yeah. So how do I select? I mean, putting all these points together, as you pointed out, the OAS data is actually maturing in all these trials, and some of them are still not reported. But one important take home for the OAS is that all of them have already reported the landmark 24 months OAS. That is if somebody is really keen on OAS, that is already available. You see that all these combinations, including Nivo-IP, has reached 70%, and pembrolizumab is 74%, and nivo-cabozantinib is 70%, and pembro plus lenvatinib reached the 79.8, that is close to 80%. That's what I mentioned. So all of them have a second, a 2-year landmark to fall upon. Other than that, we can't be waiting for the OAS to make the decision yet, because that is still going to take time. This is what you have got right now to take away. But what you already have is the ORR. The ORR is very clearly there, and ORR is kind of correlates with the PFS also. ORR, again, if you look at the example of pembro lenvatinib, you have an ORR of around 71%, 70%. And pembroaxitinib and nivo-cabozantinib more or less equal. To me, it is 60%. And the only special issue that to be discussed about the ORR is the Ipi-Nivo, where the ORR for the whole group is only 39%. But again, if you look at some subset of the favorable risk in Ipi-Nivo, actually the ORR and the PFS is superior to sunitinib. That will be, is inferior to sunitinib, but the overall survival of the favorable risk group, it's actually superior to sunitinib. And then we have the Ipi and Nivo having that flat and all that. So you have to still take the ORR, and PFS is also very, very important and relevant, because the pembrolizumab, the 24-month PFS with hazard ratio of 0.39 is a real, message setting, saying that this is how you select the patient. Finally, what it says is that you have to look at what do you want from when you select a patient. If you want an early disease control, you need the ORR and the PFS, and that's when you have to have the VEGF there, VEGF inhibitors there. Either you combine with IO and VEGF, or you need the VEGF for early disease control. That's very, very fully understood. You want the ORR, you want the PFS, you need the VEGF there. But the VEGF inhibitors will give you cumulative toxicities. You need to remember that. But if you want to look at the late plateau and all that, then only option available now is the Ipi-Nivo combination. But then there may be a patient who is completely not eligible for immune checkpoint inhibitor. There may be several contraindications. So that's the subset of patient where you will look at a VEGF inhibitor monotherapy. And there will be a patient who will be completely not eligible for VEGF inhibitors. That is when you have to look at what you will do, either with a single agent or a doublet. This is how you make. So ORR, PFS is very, very important with the available data at this time point. OAS is maturing. The only OAS we all can talk about is the 24-month landmark OAS, as clear in solidly written there, and that's how you make a decision.
Fantastic. I think a very, very concise summary of everything that is there on this slide. What is where? Dr. Rajkumar, you said you wanted the ORR, you wanted the PFS, and when you look at the ORRs, the Ipi-Nivo, like sir said, it's 39%. And that's something which comes as a bit of a shocker to you. And this is
no, I'm not surprised with that, because IVOs are going to produce a stable disease. IVOs are going to have all kind of sort of progression and many things like that. So it's not the drug of choice when you are expecting a rapid reduction in the tumor burden. So those kind of things will become only when you have a less tumor burden. And IOTK is the one where you have a better response rates and good one. And Dr. Rajat, this is question to you, sir.
Can we go back to the slide, please? I have still not done with that slide.
You have a good experience with the Axi, so one of the better drug to use. My experience with Cabo is far better. Of course, it's not interchangeable, as you said. It's not comparator. It's not a you don't have randomized trials. But what is your experience with Cabo?
No, I didn't say it's superior. I just said I'm more comfortable just because as everybody pointed out, as Amit pointed out, we started using this from way back, and I have a very, very enduring response on to that. So we have just stuck to it. Recently, we have started, after the cabozantinib became available, we have started using 4 plus cabozantinib in some of our patients. So I'm not at all averse to that. And some of our patients, we would also want to consider pembrolizumab. So I have no problem with that.
Second line options is.
Sir, Dr. Rajkumar, can I interrupt you here? I think this discussion we can lay down because we have to finish this part of the conversation. Second line, I'm going later. If at all we have time, we'll touch upon it because we don't have time. We have to be a very specific OBTO discussion today. So, Dr. Vineet Gupta, you were saying that you wanted the OS. Now, when I show you these slides, look at the numbers. 0.73, 0.72, 0.72, 0.7. Except for this 0.80 of axi-avelumab, which is not yet been positive, everything else is bang normal. And like Dr. Raja said, you have the 24-month OS landmark survival. You don't have 36 months for everybody. There also, it's kind of similar. So what do you think? Is it still important, the OS, or, use anything, you just will reach your OS? Because like you said, second line, third line, does that matter to you?
Yeah, so I think, like I was saying earlier, so see, by increasing the drug intensity, you can always get better responses in DFS. The point is that quality of life also need to be maintained in parallel. That is very important factor.
So quality of life.
So you can, many times you can get a better quality of life by using sequential agents rather than, using the best agents upfront. So I understand that in this particular setting, the OS is similar for all of the different combinations. But the question actually was, what is most important to you? So what I would say is that still, I would say the response, the toxicity and the survival, these would come first. And definitely PFS is important. I'm not saying it is not important, but I think it would be less important than overall survival.
Sure. Dr. Sahu, you look at the subsequent treatments received, 58 versus 73, 60 versus 72, and in Nivo-Cabo only 36 versus 51. In Axi, again, only 30% have received subsequent treatment. Does that really make a difference? Because, we keep talking of second line therapy, third line, and that will push our OS. Look at the number of patients who actually receive subsequent therapy. What do you think about this?
I would not play much importance in this point because it's very difficult to just speak on one trial. The only thing I'll just add on to what others have said, all of us have to agree two things, that OS is bang on, nearly the same hazards. When you have similar OS results from across 5-6 things, one thing that is for sure is the combination is the way to go forward. Number one. Number two, how do you choose them? Then comes the other factors like the PFS and the Vora. So I think Vineet, what he spoke of, I'm supporting him. I also look at OS. If that is similar, then I look into other parameters, and response rate does matter, especially of a bulky disease.
Okay, next slide, please. So Dr. Sahu, you can take this next question as well.
Yeah.
Look at the progression rate. 18% in Nivo-EP. 18% progressive disease. We went on talking of the plateau, and 30% will have that plateau and 2-year conditional OS. But to reach there, you have to have a 1 in 5% chance of actually going a progressive disease on Nivo-EP. And that is definitely something which concerns me. What do you think of this part?
Definitely. And if you look at it across the subsets, even in lung, even in RCC, that's why they're combining the TKI, even if it's for a short term. So I feel that progressions are something we do not want it to happen. And that's why Nivo-EP, the IO combination, will not be a good agent, especially when there is a bulkier disease. You would be a little more concerned if they're near vital organs. If there's a progression, you might land up in a situation where you might not be able to salvage. And there you would like to use a combination which has a more response rate. So that is how probably you will start choosing. And I do feel that the progressions of disease percentage is a very important criteria for us when not to use IO. That's what my statement is.
Perfect. I know, when you look at it 18% and you jump and say, okay, low dose, whatever, 18% progression is something we cannot ignore.
Yeah.
Dr. Amit, Your thought.
One more. Can someone tell me? I'm not aware of the cosmic where there is. What is the PD for cosmic data?
Cosmic 313 was I'm not aware of the progression because that came in the presidential symposium. I could not find the final paper.
So if there is a lower progression, again correlates the fact that if you want to take care and if you are believing in the IO combination, the concept of it, then probably that combination will give the best of two worlds.
Dr. Sahu, there is 82% side effect, grade 3 and grade 4 toxicity in the
if I can make one statement, you look across trials of even the TKI and IO combinations in RCC, more than grade 3-4 toxicity. If you look into all the trials have reported more than 70 to 80%.
Correct. So I have put the numbers here. You can see. I have put the numbers here. So this is what. Finally, Dr. Amit, you were talking of Pembro-Lenva as one of the combinations you are comfortable. Two things. In favorable risk, we still don't have an overall survival. And what the authors say that we do have less events. But also look at the fact of this grade 3 and grade 4 toxicity of 82%. And this was alluded to by someone. 20 mg lenvatinib, we are not comfortable using that. So do you still think in a favorable risk, at least when you don't have an OS, should you still use a Pembro-Lenva or should you restrict it to the other two? I know NCCN doesn't agree with me, but I'm asking your opinion.
Just before I answer this, quickly, one comment because Sahu mentioned Cosmic 313. I think Cosmic 313 has really stumped us. You've seen the benefit in PFS in the intermediate risk and the high risk where we should have seen maximum benefit. There is no benefit. And that kind of is really shocking. So we're not able to answer what Cosmic is really, why it's doing that. You know, we would have thought that would be the best in the high risk subgroup.
We need the paper. We need the full paper.
Yeah, absolutely. So your question, I would say the message is the IO VEGF TKIs are more similar than dissimilar. So I don't think we should really fret about which IO, which TKI combination we are using. In the favorable risk, if our patients have very low burden disease, we don't need the IO. We could just do the VEGF TKI and we are perfectly correct. But if our patients are symptomatic, we should do the VEGF TKI IO combination. Now, I look at it this way: use the IO which is the combination. Use the VEGF TKI which you are most comfortable with in managing toxicity with the dosing which you think is adequate. Now, everyone has their favorites. I heard some people said Axis, some said Cabo. I am a lenvatinib person. So for me, the favorite combination is IO lenvatinib because again, we've had these combinations for a long time and we have seen our responses. And as you mentioned, though we don't have long-term trial data, we have our own patients who have crossed 3 years, 4 years. You know, we have seen that how well they do in the combination. So I think we shouldn't fret about which IO, which VEGF TKI. Use the one which you are the most comfortable with in managing toxicity. And dose reductions are required in our patients with whatever we do. It's us who has to manage the patient and give the proper dose which we think is the best for patient.
Fantastic. Next slide, please. So yes, Dr. Sahu.
Dr. Vamshi, if I can.
Yes, sir. Yeah.
I think at this point in time, the progressive disease is what you brought about. That data is also something that will catch our eye. And Ipi-Nivo has an 18% progressive disease. And again, Pembro-Axitinib has around 11% progressive disease, whereas the Pembro-Len and the Nivo-Cabozantinib has got the lowest progressive disease of about 5%. Then, I mean, you talked about the toxicity. The toxicity, the Len and the Pembro, grade 3 to 4 toxicity is around 70%. But the discontinue rate is the same for all of that. So where will I place this particular regimen? In intermediate and poor risk group, anybody who has got more than, it's not favorable, anybody who has got more than one, we come together. And then when they have a symptomatic disease and if they have a life-threatening disease status, that is particularly liver and bone is involved, that is where you have to consider the big hitters, and that must be Pembro and Lenvatinib is the first choice at this point in time. And Lenvatinib dose difficulty is fully understood. Even the original authors acknowledge that. But then you have to tailor it and take it as you go on. That will be my, number one choice if it is doable.
Perfect. So
this is just a single point. Yes. Can you go back one slide, please?
One more slide, back slide, please.
Yeah,
one slide back, please.
Yeah, only the A discontinuation rate I don't think is that high. I think these are the total discontinuation rates. And if I clearly remember, it's in single digits for the axi pembro for a adverse event discontinuation.
Next slide. So this number actually is a little bit wrong on my side of South. This number includes discontinuations of either of the two and also restarting it. So it is not permanent discontinuation. You're right that the TKI permanent discontinuation is usually in single digits. You're right on that. Right. So this is my thoughts on the last 15-20 minutes what we have discussed. When you look at all these combinations, pembrolizumab has the longest PFS. It has the best overall response rate and the CR. But it does have a highest grade 3 and 4 toxicity. Again, highest is a relative term. Everyone is comfortable with it. You're good to use. There is no OS in favorable risk. But again, looking at the ORR, looking at the PFS, I think it is still a good option there. Nivo-EP does have the longest OS in intermediate poor and the largest actual difference that has been noted in the median OS and the conditional survival and the plateau. But it does have a high PD. It does have no PFS advantage, has a low response. So something that you need to consider. Avelumab axitinib has a non-significant OS in favorable risk, but otherwise, short follow-up, no overall survival in good risk, low CR rates. Nivo-Cabo, long PFS, good ORR, short overall survival. And I'm talking numerically. The difference is only 3 months in the Nivo-Cabo arm. I don't know why it is so small, but it is small. Pembro-axitinib for me has a discontinuation, but otherwise it's like the Goldilocks phenomenon. It is neither the best nor the worst, but everywhere it fits in beautifully in everywhere. It has good ORR, it has good PFS, good OS, and it is something that is comfortable for me to use. So I think these are my thoughts. Again, everyone has given their expression. At the end of the day, nothing is perfectly right, nothing is perfectly wrong. But this is something we can use to take a call on what next to do. So I have 10 minutes left in which I'll just quickly go on a few more topics. Next slide, please. So I actually looked at a meta-analysis. You know, typically whenever we have a lot of data, we look at meta-analysis. I thought I'll get a nice answer. Unfortunately, what I got was a more jumble. Next slide. I actually Googled for meta-analysis and I found around 15 to 20 meta-analysis, all on immunotherapy-based combination. I have just put up 3 slides. Next slide. All of them were done in the last year. So you have December 21, February 21, March 22, last 1.5 years, almost the same number of trials. The only thing they could agree on was the PFS, which is best for pembrolizumab. One said OS is better for pembrolizumab, one said it is better for Nivo-Cabo, one said the poor risk should go pembrolizumab, pembro-axi intermediate. This combination is good for favorable and so on and so forth. So ultimately for me, this OS, this whole meta-analysis did not really work much. Next slide. Now the next interesting one I did see was also a meta-analysis for favorable risk, wherein they said that there was no benefit for a checkpoint inhibitor versus OS. So Dr. Raja, I would like you to take this question. No difference in OS. Difference in PFS also was not found. They found benefit only in ORR and CR. Do you really think this is a statistical jugglery because you did a meta-analysis? Your individual trials have shown the OS and PFS. Should we still say that in favorable risk, a combination is good enough? Or like you told in your interview, some cases we are okay to even use a monotherapy. Dr. Raja, sir.
Yeah, so at least you go back to, I mean, even though this meta-analysis, I think is really way off the mark. That's what I think. Because in fact, your slide probably summarized it much better than the meta-analysis, what it is. And your cloud slide looked very beautiful. Maybe I'll borrow that slide. But then there is already historical data. We have the landmark sunitinib trial single agent already versus interferon, that is 2007. And then we have the COMPARES trial, which is reported in 2011 and 12. Again, which was a classical comparison of sunitinib and pazopanib, non-inferiority. It was both are equal. But what did that trial tell us? It has given you everything that you want as the final outcome point. It has given favorable, intermediate, poor risk. Overall survival is completely reported. So you already have a complete benchmark reported. If you have a favorable risk, the COMPARES trial says that sunitinib is 42% and pazopanib is 43%, and intermediate risk 26, and poor risk sunitinib has got 9 months and pazopanib, we got 7 months. So what I'm trying to say here is that you have a very, very set benchmark to follow. But if you look at the current IO trials, I think all of them are already beating that previously set. So I believe the IO plus, TKI is the new standard of care in patients whomever can tolerate the immune checkpoint inhibitor. So the first question that you will ask is whether my patient has any contraindication for immune checkpoint inhibitors. If the answer is no, the standard of care is to move away from single agent to combine IO plus VEGF inhibitor. Unless you have certain patients who can't tolerate that, that's an individual patient discussion. So the standard of care has shifted, and then any further trial will be based on this standard of care. It must be immune checkpoint inhibitors in combination with VEGF inhibitors or double immune check. That's the standard of care now.
Perfect. So I think Dr. Sahu has made a comment saying that even in those patients with less symptoms, perhaps TKI has a role. Sahu, Dr. I'm answering that. So the same question was asked by Amish to Dr. Raja, and he agreed. If you have very few nodule metastatic sites, asymptomatic patients, there you might consider using a TKI alone, followed by a IO. However, even in that situation, a direct comparison will probably show that the combination is better than a TKI. I think that's what Dr. Raja was alluding to.
Where is the direct comparison? I would like to see that, because across the trials, what I find consistent, again, Amish will tell, we are looking at subgroup. I totally agree. But if every trial subgroup is pointing to one point, that there is nothing great difference in the TKI versus the IO plus TKI, and every trial is showing that. So there is something that is there, and we have to acknowledge that fact. So my point is, which is the trial which has shown a oncological data advantage for a TKI plus immune checkpoints in the favorable group?
Sahu, are you pointing out to the fact that we know that the PFS is different, ORR is different? I think what Sahu is pointing out is finally all of these trials have the OS reported as to be more or less the same. That's what he is trying to tell.
No, sir. Can I interrupt? I think we have only 5 minutes, so I want to cover some more topics. What Dr. Sahu is saying is, and what Dr. Amol Patel has also put, there is no OS advantage in the favorable risk group. Now,
coming to that, you add only one point to that. What were the treatment that were initiated on progression of those patients? And I think most of them ended exposing to immune checkpoint. That's what I'm trying to add here.
So that's good, sir.
So Dr. Sahu, my expression is slightly different. The question that you're asking, do we have a subset analysis saying that with 2 lung metastases or 2 sites of metastasis, IO is equal to TKI? We will never have that. We have only favorable risk, which is a broad subgroup, which includes all types. As Chandrakant pointed out, the burden itself is not one of the primary criteria used in the IMDC. The surrogate markers are used. You don't have a primary criteria saying that more.
But that adds up to the performance status, actually.
Perfectly correct. You're right.
But and the LDH.
So Sahu, you have 20 small lung metastases. They may still be perfectly asymptomatic with a normal LDH.
And LDH.
Right?
Yeah,
correct. That's my point. So that's why I'm saying we have to move on, because there's no right answer to this. Right?
Yeah.
Next slide. Again, we were looking at the PDL1. This was discussed. Does PDL1 matter? Next slide. There are some meta-analysis which again showed that if you have a positive PDL1, you may have slightly better ORR and improved PFS. Next slide. PDL1 is prognostic in a few patients, but I think the final answer is what Dr. Raja said, that right now we are not testing it. As of now, we really do not need to test the PDL1 to use these drugs. Next slide. My question will really now come to what else matters. This is where we are all decided that we are going to use symptoms, volume dependence, biology, access, and cost, which is important. Let's not forget this. Next slide. Now, certain things which we do need to look at. Yeah, next slide, please. So I'll quickly run through this. This is what I call nothing else matters, but obviously this also matters. Dr. Amit, question to you, quick rapid fire. We have only 5 minutes before Amish shuts me up. First question, next slide. Anti-PD1 versus anti-PDL1, does it matter? All the positive studies are with an anti-PD1. Next slide. Yes, Dr. Amit.
In RCC, as of now, most of the data is PD1, at least in terms of OSs. So I think as of now, more PD1 is being used. But again, we'll have to watch for more data.
So my question to you, coming back to, when we talk of whether these all are interchangeable, You're only 2 anti-PD1s, you're happy with that? Or would you want to also say, okay, look, PD1, anti-PD-L1 work similar, I'm happy to use an anti-PD-L1, though it has not been used in a clinical trial first time?
No, so we do have the data in the clinical trial. It's not that we don't have
Motion
it.
one. Okay, fair enough. I agree. Next slide.
Avelumab is there. Avelumab data is there. It's just the OS data is not there.
Perfect. Chandrakant, you made this point of the TKI. Choice of TKI, axitinib versus lenvatinib versus cabozantinib. There is some data now, which is obviously promoted more by the people using axitinib, that axitinib has a narrower band of activity, the toxicity is less, it has a shorter half-life, therefore it can have less non-overlapping toxicity with the IO. So are you convinced by this, or like a lot of the panelists, you say that look, Axi, Lenva, Cabo, as long as you know how to handle it, you're fine to use anything? Chandrakant, your thoughts on this?
So when a patient comes to me in the first visit, I want his first month to go smoothly. I want a smooth induction. So I believe vaxitinib has a smooth induction. If I give lenvatinib 20 milligram, the patient won't come back to me. That's the problem.
So you're doing a practical aspect. Dr. Rajkumar, do you agree with this? Because practically we'll give something so that patient comes back to you and not go to the doctor next door.
Data points towards Cabo is a better drug when compared to all these molecular bases. It's got to be MET and AXL inhibitions, and all the second line actions are all based on Cabo, or even in NCCN guidelines.
Okay.
I think the biologically the Cabo scores over. At least, of course, we don't have any comparison in that. I prefer to have Cabo.
Next slide.
Vamshi,
yes.
Cabozantinib, would it be not okay if there is a patient has a brain metastasis at baseline? IO combination or a Cabo combination would be my preferred, because that is the best data for brain mets are with these two drugs.
All our second line, there is no trial in the first line, none have included brain mets. So
no, the first line also.
First line, yes. That's why I agree with you. Cabo has data on brain mets. If there is
and
some
the IO,
data
and the IO combination.
Correct. Agreed with that, but again, those are rare. But yes, that's one area where you can use. Next slide. Dr. Raja, sir, I'll ask you this later, but quick question from all the panelists one by one in 2 minutes. Dr. Chandrakant, the magical duo, use any IO, use any TKI, is it the same? Because that's what we want to do in practice. Or should you stick to the clinical trial combination? Chandrakant, yes, no. Not too much time to discuss.
I would stick with whatever is there.
Dr. Vineet Govinda, your thought. Would you give any combination with anything, or say that no, I'll stick to the trial?
I'll stick to the trial.
Stick to the trial. Dr. Rajkumar, sir?
Stick to the trial.
Okay. Sahu, sir?
I stick to the trial. I'll just not use avelumab and axitinib combination.
Okay, that's fine, but you will use the trial. Dr. Raja, sir, your final thought. It's still, there is some synergism happening with the TKI and IO, you believe, and you should use only that specific combination. For example, why not use Pembro with Cabo? Dr. Rajkumar likes Cabo. Why not use Pembro and Cabo together? That's the question which I'm asking.
As I told you, I would stick to the trials.
Okay.
Because, I mean, even though the concept is there, but you still want to go with the best opening pair, I mean, different permutations were tried in, so it somehow doesn't work out in the real world scenario, be it cricket or be it your cinema, and then be it toxicity, what you are facing, that's always a better deal. So stick to the trials.
I had a small question. Why change? Why change?
Hi, Dr. Bhuvan. Nice to see you. No, I'm asking this question because in practice, what many people would say is, look, I like Dr. Rajkumar, I like Cabo, I like Pembro. Let me use both together. Since it's always
why
one.
Change? As in,
that's fine. I'm just asking. So you are saying why change at all? Perfect. Next slide. So last 2 minutes.
Why this combination came up in the first place in the trial?
Dr. Rajkumar, let's go on. We don't have time. We have last 2 minutes before Amish kicks me off. Okay, so these questions are the questions which need to be answered. Next slide. Dr. Bhuvan, low dose IO. We have somebody asked about it. Are you convinced by the evidence to use a low dose nivolumab or a low dose pembrolizumab as of today in RCC?
Unless I'm pushed to the wall, I'll not.
Unless pushed to the wall, you will not. Dr. Sahu?
I would not at this point of time, at least in RCC. No, second line maybe. Second line maybe.
Dr. Amit?
Not yet, because I need to see a little data. If there is some data, we will be tempted.
Chandrakant, I think maybe you and me are the only ones who are using this currently.
So it is giving low dose Nivo is better than not. I mean, low dose IO is better than not.
It's Chandrakant. It is first line or second line?
First line. I'm asking
any
line.
Any line is different. Second line and beyond, I would be open to that. First line is something I would be very
low dose IO is better than not giving IO.
Okay.
No,
Okay,
just,
Dr.
you know, as a
Sahu,
matter
I
of
asked
fact,
for
I was having
opinion.
as a
Dr.
matter of
Sahu,
fact, I
I
was
asked
having
for
a,
opinion, not an argument. I agree there are two thoughts on this. This is something which in the audience somebody has asked us. So I think we should
as
answer
a,
it. And
no,
again,
as
the
a matter of
answer,
fact, you know, I was having a discussion today morning because if somebody has a weight of 40, 45, that is low, having a low dose, using a low dose immuno is not a bad idea at all.
low dose is 1 mg per kg. I'm not talking about 3
Agreed.
mg per kg and giving 100 mg. That is
So,
different.
but then, you know, if you're giving it, let's say you're giving a Pembro of 200 milligram, rather if you give a Pembro
Pembro
of
give it 100. That's accepted. 2 mg per kg is an accepted dose. I am talking of low dose as in something called
0.2 milligram
ULDN,
per
as it was
kg.
told.
0.2 milligram per kg.
ULDN, as Dr. Sahu educated me about. Right? Next slide. Next slide. So again, conclusion as of today, no. Next slide. Okay, IO rechallenge. Has anybody done it? Would anybody do it? Dr. Amit?
Vamshi, you need to.
1 minute. Last slide है ये. इसके बाद एक slide and close it. Amit, IO rechallenge? Yes, no.
So selected patients, yes, because we have the Pembro
Next
and
slide.
vitamin D. So we have the Pembro data. So sometimes in selected patients, definitely we do try it.
Perfect. There is some data. There's actually a data which they tried 500 patients and they found some benefit in rechallenge, but less number, not for everybody. Next slide, please. And finally, stopping immunotherapy. I think this is something I won't touch upon. There is an analysis again which showed that some patients benefit even after stopping. But I think by and large, I think Dr. Amit will agree with me. We don't stop for everybody. I know what you do. You keep extending the duration and all. I follow your lead in that. But as a protocol, we should not stop immunotherapy. Do you agree with me?
Sir, if the
Yes, Amit. Okay, I can't hear you. There is your mute. You're on mute. So, okay. Next slide, please. So this is my summary. Basically, most of what everyone has been talking about, that IMDC criteria hold true. We need to take a multi-decision based on all the factors, including patient condition, affordability, side effect profile, availability, and disease load. One thing which I personally agree with Dr. Raja is that IO-TKI combination is the standard of care, along with IO-IO for intermediate or poor risk. In IO-TKI is still a standard of care in favorable risk. We can consider IO alone we can consider TKI alone in a low burden disease. PD-L1 testing, not yet predictive, no need to do it. Interchangeably, possible and logical, it is not proven. Please don't go ahead doing it. Dr. Bhuvan, we will not do it. That's finalized, we have agreed with that. Low dose testing is attractive, not yet proven, so let's not do it. Right, so next slide. Thank you very much. This was my presentation, and thanks to all the panel for a very, very active participation, and thanks to Dr. Amish for letting me take extra 5 minutes. Over to you.
Thank you very much, Vamshi. That was really fantastic and interesting and aggressive panel discussion. And I think that is what benefits the participants the most. I would also like to thank our supporters, Merck, for sponsoring this OBTO. And now, with the permission of Dr. Amish, I would like to invite our expert for tonight, Dr. Vineet Talwar. He is going to give his comments very crisply about whether he agrees with the views of the interviewee. Does he have additional comments based on the panel discussion? And what is the take-home message for our audience based on the discussion today? So over to you, Vineet.
Thank you, Dr. Parikh, and thank you, Amish, for giving me this opportunity. So I enjoyed this because RCC is very close to my heart. So I'll divide this into 3 parts. What are our concerns? What are the endpoints which we have thrashed out? And what would be the logical conclusion? So our concerns, we love cross-trial comparisons, and that becomes a concern sometimes. And we love post-hoc analysis. We forget the primary endpoints and we jump to the post-hoc analysis and we take it into the primary endpoint schedule. The other things, of course, are the risk stratification, the disease burden, the symptomatology of the patient, and whether the patient is performance status 3 or 4. We also look at whether the patient requires quick debulking and whether the patient is non-clear cell sometimes when we come across. And when we think about that at the back of our mind is, of course, the financial toxicity. So this had been nicely discussed by Dr. Amish when he talked to Dr. Raja during the interview. And when it came to the panel discussion, the endpoint of clinical trials, this has been nicely discussed by Dr. Vamshi. So as which has been alluded here, there are about 6 randomized controlled trials where the endpoint is the progression-free survival. So in a metastatic setting, PFS may be good initially, but once it comes to OS at the endpoint, there might be a difference. The OS generally may not be concomitant with the PFS. And having said that, when you talk of OS at 1 year or 2 years, I really don't know whether it might be sufficient to come to a conclusion. But then you can't have studies according to your whims and fancies. So at this point of time, when the OS is not conclusive or the PFS is not helping you, the second PFS, if possible, can be a surrogate marker in these patients in a metastatic setting. So the question comes, does the OS define the final endpoint? The answer is yes, which has been agreed upon by most of the panelists here. Another thing which comes is when we talk of the durability of the drug. So no doubt the responses with Ipi/Nivo were not that good. The durability was about, it was a hazard ratio about 0.69 at 5 years, which it has the longest data and probably it would never be matched. Then, of course, comes the toxicity profile, which is another very important point when it comes in the decision making. We always talk of the high CR rates and high response rates of len and pem, but when we follow it up over a period of 2 or 2.5 years, we find that the PFS may not translate into a such good durability, as about only 30% or 34% of patients are there who are continuing after 2.5 years. So there the IO plus IO, that is the Ipi/Nivo, scores better. And of course, the discontinuation rates, we talk of Ipi/Nivo, it's about 20-25%. You talk of Pemaxi, it's about 40%. So these things keep on clouding our mind. Again, we talk about the high CR rates of len and pem versus the others. So the CR rates which have been achieved by len and pem, these are never thought of earlier and never achieved earlier. But then this, I personally feel, would be applicable, as we have discussed in the panel discussion, to patients who have bulky disease. So bulky disease patients can definitely benefit with the CR, PR, or the overall response rates. Unfortunately, in RCC, we don't have durable biomarkers, apart from a small subset analysis in the Javelin 101, where there is a trend towards patients who improve or do better with a high PD-L1 vis-a-vis patients who do not have a high PD-L1. Having said that, that is the next frontier for the trials. And with that, we have to bank upon the risk stratification, that is the IMDC risk stratification. And if we see the Carmina subset analysis, there we find that the good risk and the intermediate one almost mirror the same survival rates. So again, there is a dichotomy between the intermediate 1 and intermediate 2 versus the good risk. So if you have a good risk or if you have an intermediate 1, according to the Carmina subset, they do or behave the same way. So that translates into the fact, would you like to give a doublet there, or would you just go with a single agent TKI, keeping in mind the finances and the other nuances as far as India is concerned? One thing which probably could not be discussed, which is a new phenomena, which is known as the depth of the response. And that was nicely shown in the Cabo-Nivo trial. And it was shown that patients who had a higher depth of response, something like what is there in CML, they are the ones who tend to do better than the other patients. So probably in the other trials that can be looked on. Comorbidities, of course, if a patient has diabetes or patient has nephropathy or neuropathy, that definitely has to be looked whenever you come to the decision making. But as it has been mentioned in the panel discussion, it is the comfort with the drug, which you use, and your own learning curve when you use the combination or when you use the single drug, that probably has also a bearing when you come to treating these patients. So to summarize, doublet is the way to go, whether you talk of the intermediate or poor risk. If it comes to a good risk and it is a low burden disease, I think single agent TKI can also be taken. But then in the end, the logic and the clinical discretion of the clinician is still supreme, in the background of the fact that unfortunately we don't have any robust biomarkers in RCC. So I think I'll stop here, and I thank you once again.
Thank you very much, Vineet, and I will hand over to Amish, who has raised not one but 4 fingers.
No, sir, Vineet Talwar, sir, this was one of the excellent, in fact, expert conclusion. Not only you concluded precisely, but you brought out few more points also. And that reminds me of one of the conclusion of T. Raja, sir, where, he was also ready with the concise take-home messages. I think that's why we learn from you people so much. And that's what it makes a huge difference. Vineet Talwar, sir, your depth of knowledge in RCC, we will further explore, because I think you had very good points, especially depth of response is something which we didn't cover. And that also can be one of the decision making. Thank you so much for that, sir. And I sincerely thank everyone. Today, we had a very good response to OBTO, and I would request, as I request every time, please send the comments where we can make this better and better and better. Thank you so much. Till the next time, from Parikh sir and me, till we meet the next Tuesday of next month.
Which is 11th of April.
11th of April, correct, sir.
At 7 p.m. Thank you very much. Have a wonderful rest of the day and the rest of the week. Good night.
Good night.
Thank you.
Right, sir.
Casey, you can switch off the meeting.